Good evening, everyone. And even though we are a very small group left over, my topic for today is anti-VEGF in DME, diabetic macular edema. My disclosures are I have taken few slides from Bayer, Novartis, and Roche. Now, everybody knows that diabetes is something like a pandemic. We've just gone over coronavirus, and again, diabetes is there lurking on over our heads. From 2019 to 2020, 2045, it's going to increase exponentially. And as diabetes increases, the number of diabetes increases, so will diabetic retinopathy and diabetic macular edema also. Now, questions to answer while treating: when to start therapy, choice of anti-VEGF, which protocol to adopt, what would be the endpoint, factors to consider that may affect response to therapy, and when do we consider combination therapy and studies. Just going on to the history and how we have evolved over the years for DME treatment. At one point in time, there was no treatment available for DME pre 1980s. Then came laser photocoagulation, then steroids, then anti-VEGF therapy, and different types of anti-VEGF therapy, along with um, steroids also. Now there are different types of anti-VEGFs that are available. First came pegapatinib, ranibizumab, aflibercept, brolucizumab, and now the new kid in the block about to be launched. Bevacizumab was not FDA approved, even though studies have been done. Now there are two types of studies that we have to consider. One sponsored by the industry and the other by the academics. Now DRCR net is something which we need to keep in mind. What are the lessons learned? Do we consider vision when we treat? Yes, study the protocol we showed that we can wait and watch instead of going ahead and treating either with laser or anti-VEGF, aflibercept. But 1/3 of patients were switched on to injections, and 2/3 maintained good vision without treatment. So we did not jump in to say that okay, fine, if I see diabetic macular, if the OCT findings are there, then immediately I have to treat. Now OCT classification, one thing is, now everybody would have known that center involving diabetic macular edema and non-center involving diabetic macular edema. The other thing is tractional, non-tractional. In that again we need to divide whether there's a decrease in vision or vision is being maintained. There are certain OCT biomarkers which we need to consider. One is ERM, vitreomacular adhesion, drill, intraretinal hyperreflective dots, ellipsoid zone disruption, intracystic hyperreflective material, ELM integrity, foveal eversion, and retinal artery macroaneurysm. Coming to few studies, I would just rush through them, not go into details. Now, protocol I is something which told us whether we need to give ranibizumab along with deferred or immediate laser. Even though there was an improvement in vision, but ultimately there was not much difference whether you defer or give immediate laser along with ranibizumab. So the one line that we should learn from this protocol I is the anti-VEGF therapy with monotherapy with ranibizumab is enough, and we need not do laser immediately. This is one study which has guided us to choose between the three anti-VEGFs, that is bevacizumab, aflibercept, and ranibizumab. And this has shown that aflibercept does well when compared to bevacizumab or ranibizumab in year 1, and it continues, but there's not much statistical significance between the two in terms of visual gain at year 2, between aflibercept and ranibizumab at year 2. Now, aflibercept was associated with rapid or robust anatomic changes that were superior to those observed at year 1 and maintained through year 2. So, the decrease in central subfoveal thickness was better with aflibercept compared to ranibizumab, and the least was with bevacizumab. The number of lines, the number of letters gained with Eylea was better compared to ranibizumab or bevacizumab. So aflibercept maintained a superiority over the other two drugs. Now just to touch upon brolucizumab, which is the new thing, and that has shown good results. The drying effect of brolucizumab is much better, but there are other side effects which we need to consider, especially the vasculitis. The newest drug that we have is faricimab, which is yet to be launched, probably by December. We need to wait and watch. It's an exciting thing, but we don't know how it fares well when it comes to clinical practice, which is the most important thing, and the cost of the drug. So there are studies which have been done for AMD and DME. So the Yeshomite and the Rhine are for DME, and that has been compared against aflibercept. This has shown good visual gains as well as drying up of the central subfoveal thickness reduction well with faricimab compared to aflibercept. There were not much adverse effects which are seen with faricimab. So these are the different types of anti-VEGF agents which are available in the market. We need to choose what is the best for us. Take home message: don't be in a hurry. Consider the vision. Visual acuity is good, we can wait. But if it is worsening, then we need to think whether we need to treat or not. OCT parameters, few things that we need to take into consideration. The biomarkers especially, so that we can counsel the patient well before we treat them. That's the most important thing. And not that aflibercept has shown better results, we need to look at the pocket of the patient also, whether the patient can afford it. So affordability in Indian scenario is something good that we need to consider. Even though the fixed regimens as per the studies, if we exactly follow the treatment protocol as per the RCTs or the studies, they show good improvement, but not necessarily that we need to follow them exactly how they have done in the studies. Type of anti-VEGF we need to consider depending on the multiple parameters. Communication and counseling the patient is the most important parameter that we need to look in before we go ahead and give any anti-VEGF. Thank you.